Well, good morning, good afternoon, good night to you wherever you are. Welcome to this IFCC webinar on point-of-care testing. My name is Tahir Pillay. I'm from South Africa, Pretoria, South Africa, from the University of Pretoria and the National Health Laboratory Service. And today I'd like to welcome you to what is potentially an exciting symposium on a very popular topic. And this is to do with the challenge of managing non-integrated point-of-care testing, which I'm sure many of you have had to grapple with. And so we'll be looking at the challenges and solutions. And we have a distinguished panel, an international panel with three distinguished speakers. Firstly, by way of brief introduction, Adil Khan from Philadelphia in the USA, Elena Jaffrey from Pakistan, and Jeffrey Omuse from Nairobi in Kenya. So our first speaker is going to be Adil Khan, and he's the director of point-of-care testing at Temple University and Episcopal Hospitals and the director of the chemical pathology laboratories at Temple University. He also holds an academic appointment at Temple University, Lewis Katz School of Medicine, and as an assistant professor of pathology, and he works on the role of adhesion molecules in leukocyte recruitment, and also does clinical trials of point-of-care testing devices and clinical laboratory instruments. So he's well suited to dealing with the first topic of the webinar, which is to do with the selection and evaluation of non-integrated point-of-care testing. So I'd like to welcome Professor Adil Khan.
Okay, thanks very much for that kind introduction, and hello everyone. So let me share my slides. Okay, so my talk will be on selection and evaluation of non-integrated point-of-care testing. So here's some objectives. So at the end of the lecture, you should be able to understand the purpose of point-of-care testing, know key features when selecting a point-of-care test, and know how to evaluate the performance of a point-of-care test. So first of all, let's start with the definition. So point-of-care testing is basically laboratory testing performed near the patient that generates a rapid result that enables timely clinical action for patient care. So it's basically testing of patient samples outside the confines of the clinical laboratory. So in a hospital, it can be on a lot of the inpatient floors, it can be in outpatient clinics. It's often definitely performed in the emergency department where they need to get an idea of what could be wrong with the patient. So it covers physician-performed testing, HIV testing, pregnancy testing for human chorionic gonadotrophin, Hemocolt, the usual urinalysis dipstick. And then it's also done in the OR where they need to get some information on the coagulation status of the patient. So activated clotting time is often performed. You've got blood gases, and it can also be done in the endoscopy suite as well. So the value of point-of-care testing is to improve patient care, but point-of-care testing just on its own won't be able to improve the health outcome if it's not part of a clinical pathway. And that pathway has to be focused so that the whole purpose of getting a quick result is so that the patient's care can be managed immediately. So some of the advantages of point-of-care testing is that it does not require the complex hospital infrastructure, can be done in a resource-limited settings, such as in a disaster area, or it can be in a remote rural area. And one of the disadvantages is that it's actually point-of-care testing is the fastest growing sector of laboratory diagnostics. So there's a lot of material out there which is often cheap, and it can be inaccurate as well. So that's where the big challenge is. So these are some of the different types of point of care tests. Often they're very portable. You can hold them in a hand, or you can put them on a small bench. And so some of the features that you need to look for in a point of care test is, does that system or device, does it have a system check feature? So what I mean by that is there a feature that allows you to sort of make sure that the instrument or that system is functioning correctly? So this can be like running an abnormal or a normal quality control. You can run that, and that assesses the integrity of the device. If it's a lateral flow device, it makes sure that all the capillary channels are functioning correctly. The reagents are sort of working according to the manufacturer's expected recommendations, and it also tests the user's competency on how to perform the test. Because when you run a quality control, you're going through the same process as you would with a patient sample. And also the other thing that you should look at is that is there any lockout feature which sort of doesn't allow the person to perform the test if they haven't done certain steps like a quality control. The other thing is it's important for it to be robust, because it's going to be used by different types of people with different sort of levels of experience with laboratory testing. And does it have any connectivity features? Because that can help. And again, is there any operator lockout? So often with point of care devices, depending on the type, if it's an electronic device, it often has a feature where the person has to put in a particular code, or they have to scan a barcode to get access to the device. And one of the features of that is that it makes sure that only people who have been trained or who are sort of authorized have access to the device. And this is important because the point of care test is going to be part of an algorithm of patient management. So it's important for the correct person to be using the point of care device. The other features you should look out for is, has that point of care test been used elsewhere? So you need to do your due diligence and see what literature there is out there. How well that point of care test it compares to a gold standard. There are many search engines. You've got Google Scholar, which is a free service, and PubMed is also available. So some of the publications need to be subscribed, but some are available as open access. And some of the key words that you should use when you do this search engine are to use the word correlation, validation, verification, and then the point of care test name. And then in the US, the FDA has this site where for those instruments which are being used in the US, if there's been an FDA recall on something, it gets listed. So before you buy an instrument, often people access this site to see if there's been any recalls or how well it's been performing. And then the WHO criteria also has this acronym, ASSURED, which stands for, A would stand for affordable, S would be sensitive, S specific, U for user-friendly, R for rapid, robust, E for equipment-free, D for deliverable to the end users. Okay, so there are three types of point of care tests. Those that give a quantitative result, those that give a qualitative result, such as a positive or a negative, and those that give a semi-quantitative result, like either a range or 3 pluses. So the aim of the evaluation is to determine if the point of care test is acceptable for use. And this will depend on if the instrument will be used for diagnostic purposes or for screening purposes, followed by a confirmatory test. So we're going to go to a case study. So one example of a case study would be that you're replacing a small instrument with another instrument. And the question is, how would you evaluate it? So the goal of the verification study is to ensure that the new instrument is performing as the manufacturer intended and is giving you a reliable result. So one of the first things that you would look at is the accuracy, and the accuracy is the closeness of the result to the true value. And therefore you can use patient samples, but you can use a number of different materials as well. And some of the materials that are acceptable are reference standards, calibrators, control materials that have a known value. You can use proficiency test materials with established values, and then patient samples that have been previously tested so that you know what the result is. So the simplest method would be to analyze the samples in parallel on both devices. Ideally, the test should be performed at the same time. A minimum of about 20 patient samples that span the measuring range are used. So this is an example of a device that's measuring potassium. So you've got the existing method on the x-axis and the new method on the y-axis. And you plot the results and you do some statistical analysis. You also do another method you can use the different plot, a difference plot where you've got your existing method and then you on the x-axis, and you've got the difference between the two instruments on the y-axis. So when you do this analysis, ideally the goal of the slope should be 1. The intercept should be 0. The correlation coefficient R squared should be 1 to show that it's there's a linear relationship. The bias should be as small as possible. So these are some sort of schematics of how the different analyses often appear. So A would be an example of a good agreement. In B, there's a constant positive bias. And in C, in this analysis, there's a proportional bias, which is concentration dependent. As you can see here, the bias is present at the low end and at the high end of the concentration range. So the next step is to determine some analytical goals or performance standards, or sometimes they're known as total allowable error. So this is essentially the amount of error that can be tolerated without invalidating the medical usefulness of the analytical result. So there are published analytical goals which you can use, and they allow us to assess the acceptability of the bias. And here you've got some examples, and each one has their own sort of performance standards. So you've got CAP, you've got the Spanish Society, you've got the Royal College of Pathologists in Australia. So what standard you use it's all dependent on the medical director. So For example, here's some examples. So when you look at the acceptability of the results, it's important to see whether those differences are clinically significant to implement the new method, or to see if the reference range may need to be changed depending on the instrument. If the differences are not clinically important, then the new method is acceptable. The other thing that you should look at is interference effects, and this is often they've been performed by the manufacturer. So it's important to see if the manufacturer has done any studies, and they often look at the effect of anticoagulants or leukemia or hemolysis. And there's also certain tests which can be affected by medication. So these should be in all of the limitation section of the package insert. So after accuracy, the other thing that you need to look at is the precision. And the precision is, you can define it as the repeatability of a result. So how can you get the same result again and again, and how different is the variation? Often you use two different concentrations. You often run each concentration about 20 times, and there are a number of different types of schedules. There's one known as the within day. So you run one of the concentrations 20 times in the same day, in the same run. Then you've got the other day-to-day, where you run it between days, and it's after each shutdown and startup. And then you use different operators as well to see if that can affect it as well. Next, you have the evaluation of this precision step. So this basically process measures the random error of the system. So therefore, you calculate the mean, the standard deviation, and the coefficient of variation. And the factors that are being assessed are the timing, the mixing of the reagents, temperature, heating, any pipetting features, and also person-to-person performance variation. Next, we also have clinical decision levels. So values that are chosen for this precision study must be near the clinical decision level. So this the device should perform well at the decisions, at the concentration that medical decisions will be made. So for a glucose meter, it should be around 126 milligrams per DL. So again, from the precision data, you have the mean, the standard deviation, the coefficient of variation, and this is the mean divided by the SD multiplied by 100. CVs can vary between different methods, but ideally they should be as low as possible for clinical usefulness. As a rule, less than 5% represents excellent precision. 5 to 10% is good precision. 10 to 15% represents acceptable precision for some analytes, and greater than 15% is actually poor precision. So here's an example to illustrate that. So for sodium, potassium, glucose, the imprecision is very low, so that's good for applications. If you look at creatinine, it has an imprecision of about 15.6%, which is okay for screening patients in primary care, but it may not be okay in a renal transplantation clinic, where you're looking for small changes in creatinine as a marker of organ rejection. The next step that you need to do is to do a linearity evaluation to make sure that the instrument will report results in a linear fashion over what is the analytical measuring range of the instrument. So here you would run different concentrations. So you would run assigned values, and you would see if you can get the correct result, and it should be linear. So those are quantitative point of care tests. Next, we come to qualitative and semi-quantitative tests. So how would you evaluate them? So those would be done in a similar way. So an example here is the pregnancy kit, which measures human chorionic gonadotropin. So here you would run 20 patient samples that are known to be negative and 20 samples that are known to be positive. And you would see if the results between the two are the same. So some of the negative and positive results that you measure should have values that are near the cutoff, and you would also determine the reliability of the result at the cutoff. Regarding the analytical goals for qualitative tests, so the two main performance indicators of qualitative tests are sensitivity. So that's the probability of classifying a diseased patient as diseased. So here, what you're measuring is you've got the number of diseased patients with a positive result divided by the total number of diseased patients multiplied by 100 to get a percentage. So that's the same as the number of true positive divided by the true positives plus the false negatives. So that's the sensitivity. So then you also have the specificity. This is the probability of correctly classifying a non-diseased person as non-diseased, i.e. a true negative rate. So this is basically the number of true negatives divided by true negatives plus false positives multiplied by 100. And this is sort of analysis of those numbers. So it's important to realize that ideally sensitivity and specificity, they should be 100%, but often it's hard to achieve that. But it's important to bear in mind that a high sensitivity means that people who will not have the disease will also test positive. A test with a poor sensitivity means that people who have the disease will test negative. So therefore, a test with a high specificity will limit the number of false positives. So that's important to know. Great, thank you very much.
Thank you very much, Professor Khan. So now you've chosen your point of care instrument with the right sensitivity and specificity, if it's a qualitative test, or with the right accuracy and precision. Now, what do you do next? So the question is, how do you manage quality control with a non-integrated point of care test? And that's the subject of our next speaker. So Lena Jeffrey, and that's where we go across the world to Pakistan, to the Aga Khan University, where we have Professor Lena Jeffrey, who is an associate professor and section head of chemical pathology in the Department of Laboratory Medicine at the Aga Khan University. She works on inborn errors of metabolism and rare disorders of bone, and her interests also include distance learning. But recently, and she will mention this, she's also been working on a framework for non-integrated point of care testing, particularly in lower middle income countries. And so without further ado, I would like to welcome Lena Jeffrey. Thank you.
Thank you so much for the kind introduction, Dr. Tahir Pillai, and good evening from Pakistan, everyone. So I have a little tricky topic to present today, but let's see. So the roadmap of my talk would be that together we will go through the concept of IQCP, which is the individualized quality control process program and its relevance to non-integrated POCT. Those of you who do not know what non-integrated POCT is, hang in there because I'll take you through that also. Then I'll explain the importance of risk assessment in IQCP. I'll be using this term IQCP, and together we will develop a IQCP plan for a case study and relate it to the training needs. So, like all of you by now know that point of care testing refers to laboratory testing that is done very close to the patient, near to the patient, or often at the bedside or outpatient clinics. However, what is now non-integrated point of care testing? Non-integrated point of care testing is nothing but point POCT that is not directly or completely linked to the laboratory information system and lacks in full integration with LIMS. So it can measure single analyte or multiple analyte. So the issue is the integration or the connectivity with your laboratory information system and eventually with the hospital information system. So there are multiple challenges with non-integrated point of care testing system. That is why many of the hospitals try to, avoid non-integrated POCT as far as they can. And it's always easy to go with the right, it's even easier when you have an integrated POCT if you are CAP accredited or you have strict regulatory body looking, oversighting you, then it's always easy to go with integrated POCT. However, we need to discuss the challenges and the solutions for non-integrated POCT. I'll tell you why in a little while. So of course, with limited connectivity, there's lack of integration with electronic records. Of course, whenever there's lack of electronic records connectivity and data transmission, the challenges of review and manual data entry, of course, again, they were, are more prone to errors. So another thing that lies with whenever there's manual entry and less connectivity or limited connectivity is the undetected risk that might go unnoticed and affect patient safety or outcome. Manual procedures add to work of, like, laboratory professionals are already working under stress and are already have a lot to do. So manual equipment checks, manual reagent quality checks, manual QC data entry, manual patient entry, all give you, add to the challenges of non-integrated POCT. Then the regulatory compliance, whenever there's manual review, manual entry, adds to the burden of the challenges of non-integrated POCT. Again, there's an increased burden of documentation, and you might be asked to do more frequent audits and process improvement. Then again, maintenance and calibration becomes an issue when everything is not, manual. So logs and documentation again becomes a hassle at times. So it's important to understand that quality control is very important, especially when you have non-integrated POCT in place in your hospital or in your academic medical center, and patient decisions of patient management are taken on it. So it's very difficult to maintain uniform QC standards like you do in your lab or with integrated POCT. So the POCT director, whoever is leading the point of care testing program from your lab, has to play a very important role here. So there's greater risk of errors and variability. So besides all these, and again, another challenge, which is I feel the biggest challenge is the training need and the competency that needs to be reviewed again and again. So there's need of extensive staff training, especially if you have high attrition in your institute, and there's a potential for inconsistent user competency, especially if there's high attrition. So these are the few challenges, but it's all right. I don't want you to, these are not for haunting you or to make you scared. So let's move towards a solution. So, like that there is a individualized quality control program, especially for non-waved or moderate and complexity testing tests in the laboratory, especially those in which you do not have certain quality requirements like external QC, etc. But it's very important to understand that IQCP can be applied on non-integrated point of care testing, especially if patient decision is being taken on it. So, what is IQCP? It is nothing but a framework for customizing or making your own QC program depending on the non integrated POCT test that you are proposing or are trying to initiate in your hospital, and also depending on how it will be used, whether it will be used for screening, diagnosis, management, etc. So, it's a customized voluntary QC program for specific especially for an environment like non-integrated non-integrated POCT. One thing that I want all of you to remember is that there are three components of IQCP, and it's although I've drawn it like a circle, but always it starts from the first one, that is risk assessment. That you need to identify the risk, or the potential risks that can, or errors that can happen if this non-integrated point of care testing is initiated in your hospital. Then you go based on the risk assessment, you go with the QC plan, the customized QC plan that you develop for that particular test. And for that, to keep a check on that, you need to have a quality assessment program also. So it's an ongoing process, of course. Firstly, you start with risk assessment, but you have to keep a check, and so it's like a circle. So let's go quickly through the risk assessment strategy. That is the first step whenever you want to introduce a non-integrated POCT test. One example can be the dipstick test, the lateral flow that are used for infectious diseases, and any point of care test does not, is not transmitted to your ILMS, whether it's qualitative or quantitative or semi-quantitative. So you need to identify risk in all the three phases of testing, that is from pre-analytical to analytical and post-analytical. Now, what I've highlighted as red are the minimum 5 areas that at least you should take care of. That is the specimen, the type of specimen, and whatever comes with the variability of the specimen, the test system, reagents, environment, and the testing personnel. So these are minimum 5 things that you need to take care of whenever the risk assessment strategy is being carried out. So these are basically potential errors or potential failures of a non-integrated that you are planning before implementing it. Then moving on from the results of your risk assessment, you move on to developing your own particular QC plan, whether you want it strict, stringent, or you want it relaxed, depends on the type of, the results from the risk assessment that you got. I'll take you through it in our case study. But the QC plan is, individualized QC plan for the particular test. So I'll just quickly go through the bullets that I've listed down. So you have to specify the QC practices, protocols, resources, anything unusual with this test, you need to identify it in the SOPs. You define the acceptable performance criteria, the QC limits, establish frequency and types of QC that will be run, outline the frequency of audits, availability of troubleshooting guide for physicians or end users. You compare the results with central lab accuracy, precision, and make a periodic, schedule for this, develop training programs, curriculum for that particular test, and design the competency forms. To keep a check on this QC, the third part, if you remember, I told you there are 3 components of IQCP, is the quality assessment. Now, quality assessment is nothing but to keep a check of the compliance of your quality control program that you just laid down for that particular test. So what I've shown you here is everything that was related to the QC plan, but reviewing the data and the laws and documentation. Remember, this is non-integrated POCT. There is chance that majority of the work will be done manually. So it might be partly integrated or completely non-integrated, but this is a lot of work. So you need to have a process laid down, and supposing, it's a critical test, and with, The risk assessment showed that it might harm the patient if there's a wrong value reported. So you might have to review the QC, manual QC on daily basis if possible. Now, I would like all of you to close your eyes. Do not go to sleep, but picture this. Now, imagine that you are the director of point of care testing program at a hospital in Peace Valley, and it's November 2025. Colleagues from your hospital emergency department reach out to you for a help. They need some assistance. So there's a Sneezezilla outbreak. Peace Valley, remember, is a fictional city. It is no city in Pakistan or nearby. So it's a fictional city which has faced a sudden outbreak of a novel respiratory virus, the Sneezezilla outbreak, and healthcare facilities are overwhelmed with the flu-like patients coming in with high morbidity and mortality. Now, there is Sneezezilla lab testing available in your lab, but there is a lot of delay and the turnaround time is not ideal for these patients and physicians. So there's a pressing need for a point of care test closer to patients to ensure rapid turnaround time. Hence, as a POCT director, you are approached from your hospital colleagues, from ER, and how will you navigate this? So the lab, of course, will not say no. As always, you would like to help them. So you try to identify the problem first. So you know that there's an urgent need for rapid testing near patients, and point of care for Sneezezilla is available, but non-integrated. So it is not integrated. So there you go. Internal QC is built into the system. You look at the system, it runs with every patient sample, but unfortunately, there's no external quality control available. So what would you like to do? You cannot say no. You think and you implement the non-integrated POCT only after addressing the IQCP related queries. Now, there are few questions that need to be addressed whenever you are laying down the IQCP plan. What diagnostic challenges does the Sneezezilla test aim to address? Is it just a wish list from the physician, or there's an actual need or pressing need of this test? Is this non-integrated even cost effective for the cost effective? Is the test available in the central lab for comparison and for confirmation? Because remember that point of care testing are slightly less sensitive and specific as compared to laboratory tests. This is a general statement. So are there any internal and external QC material available? So you'd like to give a quick check again. Is the procedure user-friendly and simple? And what are the potential risks to the patient because of non-integration with LIMS? So you start from here, and then you also try to identify how you will control these risks before implementing it into the hospital or the patient care area. Remember why you are doing this, because now this is going out of your hand and the environment will not be the lab where this testing will be done. So the best way you think of is laying down the curriculum. So you lay down the curriculum for training of physicians and end users, and you lay down the, give them an idea of I will not go into the detail. I will quickly give you the heading, the overview of the program, how to operate the instrument, what are the issues with pre-analytical, analytical, and post-analytical that you would like to teach them. And with, of course, with skills, how will they enter the data? Even if there's manual entry or there's some form of transmission you would like to teach them, how will they interpret this? How will the reports be generated, if any? If it's manual entry, how will it be done? And then how will issues like infection control and everything else taken care of? So you would like to make a proper curriculum. Now let's assess the risk using a 5x5 risk assessment matrix. I'm sure most of you have gone through this in your practice. So this is a breakdown of how a 5x5 risk assessment matrix works. The 5 rows represent the likelihood or probability of the risk occurring, while the column represent the severity of the consequences. And each cell in the matrix represents a level of risk, with the highest risk in the red area or the top right corner and the lowest in the bottom left corner shown as green. So this will guide you whether this should be introduced in the hospital care or the patient care area or not. Also, this will also guide you with the QC plan. So this is just an example that you would like to say that one of the risks could be incorrect specimen type. You do this for every pre-analytical, analytical, and post-analytical phases. But one example that I've given is that incorrect specimen type may be not a very frequent but an equational error, but it is a serious error, hence marked as red or critical. So this is just a quick, I've tried to, give you an example how, from problem to solution to monitoring and prevention, it lies with the laboratory. This is the responsibility of the laboratory, and you have to lay it down whenever you are doing the risk assessment for IQCP. So lab finally provided a solution. There was no significant issues that was found that cannot be mitigated, and all the risks were assessed. Strict QC plan was laid down for this new virus. Quality assurance checks were defined. Responsibility of lab director was identified as the main lead for this test, even in patient care area, and the non-integrated POCT was finally added in the POCT program. So this was the final. So this is from where I come. I'm from AKU, Khan University, Karachi. This is my hospital. Why I'm showing you this? Because I would quickly like to share my experience. We started POCT program a decade ago, and the lab, of course, I'm the POCT director, has a strict oversight and governance of this. We have quick, strict document control, process improvement, like all the processes which Dr. Adil just mentioned. But our program is also under regulatory, checks by CAP and JCIA. The interesting thing is that the program did not include non-integrated POCT till only recently, that is April 2024. So this is how we evolved in Pakistan through education. This is basically my institute's educational journey from integrated to non-integrated POCT. How? Because this was in 2012 that we understood that there was a need of a POCT curriculum that was laid down, competency assessment form. We've come a long way with local, national, and POCT seminars with international collaborators like Dr. Tahir Pillai and Dr. Adil Khan. So then finally we got to understand that there was a need for a policy for non-integrated POCT, which was just recently developed and it's under review. But one thing that we did was that this policy, the scope is only for physicians, as they will be the main stakeholders taking the decision or the managing the patient. So hence we've just kept it for the end users will be physicians only. So this is my journey that I wanted to share. Just to conclude my presentation, remember that non-integrated POCT should not be encouraged if you do not have a strict oversight of it. So it should only be considered for critical patient survival need if you are taking decisions for patients on it. IQCP for non-integrated is critical for ensuring the result reliability, accuracy, to enhance the patient safety, of course, and also it gives you evidence-based quality assurances. Remember that you need to understand and remember always that it starts from risk assessment. You need to do the risk assessment. If it comes in the red zone and you're not able to control it, then do not go for non-integrated POCT. However, if you're able to control the risk and you have a plan to monitor it and continuously monitor it, then you can go for it. So that is one of course, like Dr. Tahir just said, that I would like to share that with my colleagues and local experts on point of care testing, we were able to develop a framework for LMICs. And if you really want to go into the detail of non-integrated POCT, this is a good article which is easily accessible, and this is my POCT portfolio. Interestingly, all on EG-IFCC. So kindly go through them if you really want to know that what we have achieved so far. And thank you very much.
Thank you very much for that, Lena. Just listening to your talk brought back some thoughts to me. I was sitting at the breakfast table with my 82-year-old mother, and she was doing her finger prick glucose testing and writing the results in a notebook. And I thought that must be the most common example of non-integrated point of care testing. And the other thing you just made me realize, I didn't actually think about checking her competence or checking her quality control, which is something I need to do the next time. And that sort of makes us segue nicely into the next talk on continuous glucose monitoring. And I'd like to welcome now, again, across another journey across the world, back to my home continent, Africa, Professor Jeffrey Omuse from the Aga Khan University, where he's in Nairobi, where he's the associate professor and consultant clinical pathologist at the Aga Khan University Hospital. He's also current chairman of the Kenyan Association of Clinical Pathologists. He's been running the clinical chemistry section as well as the Master of Medicine program in clinical pathology at the university. And he's also country lead for a study that's being undertaken by the IFCC on reference intervals. And I'd like to welcome Jeffrey. Thank you.
Thank you very much, Professor Pillay and IFCC for organizing this webinar and giving me an opportunity to speak about continuous glucose monitoring, which is actually not a very new technology. It's quite old, probably over 20 years old, but it's by and large making its entry into LMICs. Certainly in Kenya, our experience with continuous glucose monitoring is probably only 2 years old. And I'm attempt to talk about opportunities, challenges, and I put a question mark at the end of solutions because I'm not sure we have all answers to all the questions. Listening to Lina Jeffrey speak, I am envious that you can easily develop an IQCP for some tests. I think my question to Lina would be, can you develop an IQCP for continuous glucose monitoring? I have no conflicts of interest that are relative to this presentation. I hope in the next 20 minutes to quickly look at, again, just remind us what CGM is, what it is used for, what are the various types, what are some of the training needs, in particular emphasis on what role we as laboratorians actually play in its adoption, highlight what the IFCC working group on CGM is trying to do about it. What are some of the considerations when you look at clinical performance evaluation? Look at the CGM metrics for clinical care and wrap up by just quickly addressing some of the challenges and solutions. So, Tahir, just confirm that you can see my slides and that they're moving?
Yes, we can see them. Thanks.
Thank you. So by definition, continuous glucose monitoring is basically refers to the use of small wearable biosensor devices to measure glucose in the interstitial fluid. And this is really done on a continuous basis through the use of a sensor, an electrochemical biosensor that is basically inserted in your subcutaneous tissue. So unlike traditional blood glucose monitoring that is done at home, like Professor Pillay mentioned his grandmother, this is actually done on interstitial fluid. And interstitial fluid is found in the extravascular space. And so therein already highlights one important difference between what continuous glucose monitoring does compared to traditional blood glucose monitoring. And indeed, CGM has revolutionized the management of diabetes, especially that of type 1 diabetics on insulin, type 2 diabetics who are either on insulin or oral hypoglycemic agents that actually have the risk of hypoglycemia, like sulfonylureas, or diabetics who have unexplained frequent hypoglycemic episodes, or your typical diabetic, type 2 diabetic, who for some reason or another, despite all attempts at optimizing their control, you're unable to achieve the pre-specified targets. Now, the evidence for the benefit of using continuous glucose monitoring is very vast when you look at the literature. And if you look at one of the earlier studies published in 2010, and that is the JDRF CGM trial, it was very clear that use or adoption of CGM actually translates into a reduction in elevated hemoglobin A1C, of course, assuming that you actually respond to the continuous data being given to you by CGM. And these reductions in hemoglobin A1C are actually dependent on what your baseline hemoglobin A1C was. So those people who had higher levels of hemoglobin A1C actually seemed to benefit much more from the use of a CGM. And the benefit was pretty much across all age groups, with the exception of participants in the age group of 8 to 24, which by and large comprises your adolescents. And sub-analysis of this data actually demonstrated that those, even in this age group, who were able to use continuous glucose monitoring for at least 6 days in a week actually benefited from its use. And number 4, which again is very important when you think about acute complications in diabetes, there was a significant reduction in the episodes of hypoglycemia, up to even 50% reductions, which is extremely important for diabetics, especially type 1 diabetics. So if you try to compare and contrast traditional self-monitoring blood glucose and CGM, what becomes very apparent is that even if you did 4 to 6 finger pricks and measured your blood glucose using a blood glucose meter, there's actually a risk that you may miss episodes of hyper or episodes of hypoglycemia within your 24-hour cycle by simply monitoring your glucose at certain specified time points. So there is indeed a benefit of carrying out or being able to do continuous glucose monitoring, as it gives you an opportunity to actually intervene and avoid these spikes and troughs. So traditionally, we would monitor diabetics using glycated hemoglobin, which by and large still remains the gold standard for monitoring response to treatment and intensifying your treatment to achieve specific targets. But it is important to note that hemoglobin A1C actually tells you a story over the past 90 days. And in essence, it tells you what your estimated average glucose would be over the past 90 days. Now, if you look at these 3 charts, each of these individuals actually have an estimated average blood glucose of around 8.5 millimoles per liter, which is sort of the equivalent of a hemoglobin A1C of 7%. And what you can clearly note, whereas this last individual has never had a hypo or a hyperglycemic episode, his estimated average glucose remains 8.5. However, if you look at the first individual here, has had this very many episodes of hyperglycemia and episodes of hypoglycemia, but overall, when you look at the average of his glucose, it's still 8.5. So hemoglobin A1C is good for monitoring, but hemoglobin A1C does not give you the advantage of knowing how your glucose control is in the course of the day. Further, hemoglobin A1C can vary based on certain pathologies. For instance, we know that patients who have hemolysis or any condition that significantly reduces your red blood cell lifespan will result in lower hemoglobin A1C. And on the flip side, anyone who has a condition that increases the lifespan of your red blood cell, like iron deficiency anemia, will end up having higher levels of hemoglobin A1C. And we also know that there is variation in the rate of glycation in hemoglobin A1C across races and ethnicity. So hemoglobin A1C does indeed have its challenges. So then what are the benefits of using CGM? So as mentioned, number 1, it provides you an opportunity to offer real-time, actionable glycemic monitoring to your patient. It reduces your finger pricks because once you insert the sensor, it stays there for anything between 7 to 14 days, depending on the manufacturer. It offers an opportunity for shared decision making, and this simply because you can actually integrate a continuous glucose monitor, and your healthcare provider can actually see if you allow them to, and based on the specific device, they're actually able to access your individual glucose monitoring data. And so together, you as a patient and your healthcare provider can actually work together to achieve better targets. And number 4, there is actually use of CGMs that are actually integrated to insulin pumps in what is called a closed loop. Then you're able to tailor-make your insulin infusion based on your glucose level at that point in time. However, it is worth noting that since we are measuring glucose levels in interstitial fluid, which is in an extravascular space, there is sometimes a lag of between 6 to 10 minutes for your blood glucose to equilibrate with your glucose in the interstitium. There's number two, there's also a risk of data overload because you're getting so much data over a very small period of time. And depending on one's personality, this can be the cause of a lot of anxiety. For healthcare practitioners, there's a bit of apprehension because by being able to access these vast amounts of data, then as a healthcare provider, you need to invest in terms of time to learn how to interpret this new technology. And you need to even dedicate staff who will be responsive to the needs of your patient, given that this data can be accessed by you on a real-time basis. Finally, it is again, since we're measuring glucose in the interstitium, there are certain conditions where a measurement of interstitial glucose is not accurate. And this is, for instance, in cases where one is dehydrated, has hypotension, or is in shock, or people who have hyperglycemic hyposmolar states. So there are various types of CGMs divided based on use, so either professional or personal. And this really speaks to who exactly is using it. So the professional CGMs are basically given to a patient by the healthcare provider, who then is able to either monitor on a real-time basis the data, or is able to download this data when the patient visits them. And they have the option of blinding the patient to this data or not. The personal CGMs is really for personal home use, and they're broadly classified into two types: your real-time CGM and your intermittently scanned CGM. The difference here is that for the real-time, as it says, it has a transmitter that basically picks a signal from the sensor that has been inserted and sends this on a real-time basis, either to a reader or to a receiver. And this receiver can actually even be a mobile phone that has specific apps to capture this data. For the intermittently scanned, this may or may not have a transmitter. And for you to access data, you either have to pass the reader over the sensor device, and then it's able to download data that has been collected and stored up to a maximum of 8 hours. So the benefits of using a real-time CGM is that you can actually integrate alerts so that it can tell you when your glucose levels are high or low or are trending towards increasing or decreasing, and this provides you an opportunity to actually intervene. So between the real-time and the intermittently scanned CGM, which one confers benefit to you as a patient? So if you look at hemoglobin A1C as a primary endpoint, it has been found, and this was in a prospective randomized multi-center trial, that patients who actually were given a real-time CGM, these are type 1 diabetics, actually were able to achieve better control compared to people who are using intermittently scanned CGM. And this actually also translated to reduced episodes of hyperglycemia or hypoglycemia, and an increase in the percentage of time that one's glucose was actually in a desirable range. So there are numerous brands of CGM. I think the market is dominated by Abbott and Dexcom. But it is worth noting that there are now CGMs that do not require calibration, that they're actually calibrated by the manufacturer. And we also have CGMs that are actually approved for use in children. And this is very important, especially for type 1 diabetics. Now, over the past 20 years, a considerable improvement in CGMs has been the extent or the analytical point accuracy. Over the years, CGMs have been able to have improved significantly in terms of the accuracy. And this is shown by this graph that shows that the mean absolute relative difference compared to a reference blood glucose measurement has significantly reduced over the years, which basically points to improvements in both imprecision and bias. And this is very important, especially given that we do now have continuous glucose monitors that have been integrated into a closed loop with insulin pumps, where you do have communication between your continuous glucose monitor and an insulin pump to better titrate your insulin dose based on your level of glucose. And this, in essence, plays the role of a pancreas. So this is quite exciting given this kind of advancement. So the question therefore is, what are the training needs? And I think more importantly, as laboratory professionals, what role do we play in adoption of continuous glucose monitors? As I did mention, this is technology that is up to 20 years old, but is now being adopted in developing countries. And as I did mention, in Kenya, our use of CGMs is hardly 2 years old. So there is sort of a gap, but fortunately, the IFCC and other similar bodies have actually taken up the challenge to sort of come and define certain parameters or certain issues that are pertinent to us as laboratory professionals. And these include, one, issues around metrological traceability of glucose values obtained by a CGM. And why this is important is that to date, we really do not have a reference method to accurately measure glucose in interstitial fluid. So you'll find that most of the studies on accuracy are done compared to either a blood glucose meter or measurement of glucose in a laboratory analyzer. The other important issue that the IFCC working group is trying to look at is assessment of analytical performance. How do you assess analytical performance of a CGM? It certainly is not exactly the same as a blood glucose meter, given the frequency of measurements. A CGM can actually measure blood glucose every 5 minutes. And so what performance criteria would you want to assess? And finally, for you to say that a CGM is actually fit for purpose, what would be your acceptance criteria for analytical performance? So as I did indicate, part of the challenge is that if I am measuring or want to assess the performance of a continuous glucose monitor, what do I want to compare that glucose to? Do I want to compare it to a glucose level in capillary blood? Do I want to compare it to venous blood? What is the ideal comparator? There is really no consensus on which is the best comparator, especially when you consider that in essence, a continuous glucose monitor by and large will be used at home, especially for a personal CGM. Should we then use capillary blood glucose measurement as our comparator? Number two, what glucose measurement method should you compare against? Most continuous glucose monitors actually use glucose oxidase. So you have an electrochemical sensor that basically picks up a signal after glucose oxidase reaction. So is it okay to compare that to, for instance, a hexokinase method in a main laboratory, when we know that there are actually method-specific biases in some of even the laboratory-based methods? And finally, should we harmonize? Should we have harmonization of comparator measurements? And what do I mean here? If you're going to compare a CGM measurement to that of a self-monitoring blood glucose device, the blood glucose device also has inherent biases. And so is it possible then to have measurements done for some of the samples using a higher order method? Then you recalibrate your data so that your comparisons are actually related to a higher order method. So these are some of the challenges when it comes to identifying what is the ideal comparator when you're evaluating a CGM. Now, as I did mention, accuracy is very important as a parameter when you're assessing or evaluating a continuous glucose monitor. And if you look at published literature, just on reporting on analytic point accuracy, there appears to be no consensus on which is really the best method to report accuracy. Most studies report what is described as your mean absolute relative difference. But there are people who prefer error grid analysis, those who prefer agreement rate, those who prefer reporting biases or plotting Bland-Altman plots. So we need consensus in terms of which is the best way of assessing analytical point accuracy, because this is important, especially when you're using a CGM to alter your insulin dose or the frequency of your insulin dose or any subsequent management. So there is at least some advancement in terms of acceptance criteria when you're looking at analytic point accuracy. And in 2018, the US FDA actually published requirements, minimum requirements that need to be achieved by a continuous glucose meter. And they are very similar to what is used for blood glucose meters. And you can clearly see that the requirements actually vary based on what concentration you're actually comparing. But by and large, a difference of plus or minus 0.83 millimoles per liter for concentrations less than 3.9 millimoles per liter is considered acceptable. And for concentrations above that, you have to be within plus or minus 15%. For the ISO, their criteria is slightly different, is that they expect 95% of readings when you're comparing to a reference blood glucose measurement to be within plus or minus 15%, and that 99% of pooled results shall fall within zones A and B if you're doing an error grid analysis. So other important aspects to look at when you're trying to assess the performance of CGM are, I've really talked about accuracy, but it is important to highlight the issue about trend. So CGM does not only give you real-time data, but it also has the capability, the software has the capability to tell you what is the trend of your specific glucose measurements. And this is important because it is no use of having an alarm on a CGM when you're already hypoglycemic and you're already suffering from neuroglycopenia and you're already collapsing. You actually want a warning to come early enough to actually give you enough time to make an intervention. So it is important when we're assessing accuracy to actually look at, even when you're comparing against a reference blood glucose measurement, that the trend in terms of is it increasing, is it reducing, is it stable, is also similar. It's not just enough to look at value for value, but the trend is also important. We usually assess stability. So for instance, your sensor, if a manufacturer says that your sensor is stable for 14 days, it is good to actually confirm that indeed for 14 days, your sensor will actually work in a predictable fashion. And this is important because when you look at your ambulatory glucose profile, you need a minimum of 70% of 14 days, data worth 70% of 14 days to be able to get reliable information. It is important to assess also your calibration, that your calibration actually is stable throughout the period that the manufacturer says your calibration should be stable. Alert reliability, again, speaks on whether you get alarm for hypo or hyperglycemia when you hit specific thresholds, and also when the trend of your measurements are pointing towards danger, either a hypo or hyperglycemic episode, and these alarms are usually earlier than your thresholds for actual hypo or hyperglycemia. Technical reliability basically looks at robustness of the device, and user satisfaction is basically about how user-friendly, how wearable is this as a device. So these are all important considerations when you're looking at a CGM. Now, the report you get on a display of a continuous glucose monitor looks something like what I'm showing here. And the beauty is that this has basically been standardized across many of the CGM meters. So this is called an ambulatory glucose profile report. And in this, you can actually see very many important things. Number one at the top here, it says how many days has this device been active. Like in this particular example, it has been 13 days. And you can see that of these 13 days, the CGM has actually been active for 99.9% of the time, which is extremely important because your threshold is usually 70%. The other key things that are shown here is it gives you an estimate of your average glucose. And based on this average glucose, it is able to compute what I call an equivalent of your hemoglobin A1C that is called glucose management indicator. And this is fairly reliable so long as you've not had acute episodes of spikes or troughs of your glucose. And this can be roughly be interpreted almost like your hemoglobin A1C. And it also gives you a sense of the variability of your glucose during a specified time period. In this case, the CV was 49.5%. The desirable CV is less than 36%. But more importantly, the concept that is actually in vogue and maybe the most useful is what we call the time in range. The time in range depicted by the green lines on this graph basically tells you what percentage of your readings within a specified time while between 3.9 and 10 millimoles per liter. And why is this important? This is important because studies have clearly shown that the longer your time in range, this correlates very well with your hemoglobin A1C and actually correlates very well with the risk of developing both macro and microvascular complications. The graph or the ambulatory glucose profile also gives you data on how long you have been above the target range, so that is a TAR, and the time below range, which is a TBR. And this is all depicted in color here. So the green is your target range. The high is slightly above. The very high in this particular example is over 13.9 millimoles per liter. And down here, the very low is less than 3 millimoles per liter, which is in essence is a point at which you're truly hypoglycemic, and you can actually start having central nervous system symptoms. So it is also important to note that your targets in terms of time in range are not standard across everyone. It actually depends upon the kind of patient who's using the CGM. But by and large, for most type 1 and type 2 diabetics who don't have complications, you want a time in range of at least 70%. This is a bit different for older people, where we say that your time in range is around 50%, but our time below range is actually reduced to a threshold of 3.9 because we really do not want episodes of hypoglycemia. CGM has also been used in type 1 diabetics, women who are actually pregnant. In the US, I don't think it's FDA approved for this, but it is still used as an off-label. But we have slightly tighter ranges. In this case, it's 3.5 to 7.8 millimoles per liter. And for pregnant women who are type 1 diabetics, we expect them to achieve this in at least 70% of the time. So the message here really is that one size doesn't fit all. We talk about achieving a time in range of 70%, but this again is variable depending on your patient type. One of the things that I would like to highlight as I move towards the end of my presentation is the issue about arrows. So a very important part of a display of a CGM is an arrow that basically tells you the trend of your readings, whether your readings are going up, whether your readings are going down, or whether your readings are more or less stable. And as I had alluded to earlier, what these arrows actually mean for a particular CGM monitor is very important. Because, for instance, if you look at a Freestyle Libre CGM, a horizontal arrow basically tells you that the change in your glucose values is less than 0.06 millimoles per liter per minute, which basically means that the change is more or less negligible. But if you have an arrow that is pointing up, it means that the change in your glucose is around 0.11 millimoles per liter per minute. And so if someone has, for instance, a glucose level of 3.5, so a level of, say, 10 millimoles per liter, and you're seeing an upward arrow, you can predict that in the next maybe 30 minutes, that value is going to be somewhere over maybe approaching 10.5 millimoles per liter per minute. And this can actually alter the behavior of that individual. They might decide to skip a meal if they're just about to eat a meal. And so this kind of information about trend is actually very important for a patient. So in terms of interpreting an ambulatory glucose profile, I've already highlighted some of the key considerations. One is that you need to ensure that your data is complete, that at least if it is a 14-day CGM, if you have 14-day CGM data, you need to have complete data for at least 70% of the time. You need to review your individual's daily routine with specific emphasis around exercise, food intake, when they take the medication, and things around stress, because this can actually cause variations in your continuous glucose monitor readings. You need to identify hypoglycemic episodes and what precedes these episodes, what are the triggers, and you need to relate this to dosing, especially in type 1 diabetics, what kind of insulin they're given and what dose and at what time. You need to evaluate day-to-day variability, because beyond just having your glucose within a specified time and range, variability has been shown to be related to adverse outcomes in diabetics. And finally, you need to have a target time and range and be able to discuss with the patient, individualize this time and range individualize your alarms so that then your patient doesn't really suffer from having too many alarms. So finally, what are the challenges and solutions? The biggest challenges in LMICs, and certainly Kenya here in sub-Saharan Africa, is cost. CGMs are very expensive. In Kenya, to use a CGM for 1 month, the cost of just replacing the sensor is between $200 and $300, which is way above many people's earnings. Only 2 global insurance companies are able to pay for CGMs, so access is really a problem. Of course, to overcome this, we can't try and use professional CGMs, and we are currently trying to lobby for insurance companies to at least pay for use of a professional CGM, either once or twice in a year, especially for type 1 diabetics, to get a sense of how the medication being given to them and how their lifestyle is actually impacting on their glucose levels. There's an issue about alarm fatigue, and we have actually experienced this with our patients, that too many alarms can actually kill people's motivation to use the equipment. So again, you have to individualize these thresholds, especially for your predictive thresholds. You really need to have a discussion with your patient. The challenges with the device usage, especially data gaps, and this often happens when someone is too far away from your receiver device. So if you have a real-time CGM and you have a phone as your receiver device, the two oftentimes need to be within 6 meters of each other. If they are farther apart, then you'll have data gaps, which is not good because you really want to have data completeness. The issues around body placement, what the device has been approved for in terms of where to put your sensor, vis-a-vis what is practical in a real-life setting. Sometimes some of the positions that these devices have been approved for do not work, for example, for athletes or people who are engaged in certain occupations. There have been issues with skin reactions, yes, allergic reactions, and this again is a challenge. There are concerns about interference, especially certain drugs. Common drugs like paracetamol or albuterol have been known to interfere with some of the CGMs. Certain CGMs malfunction if you put pressure on them. So it is good to have all of that information available. Finally, in terms of regulation, in Kenya, for instance, right now, it is not clear who should actually regulate this. Is it the laboratory bodies? Is it the pharmacists? Is it the nurse practitioners? Is it the diabetes educators? And so there is a lacuna, and I'm sure I speak for many countries in sub-Saharan Africa, who should actually regulate the use of CGMs. Finally, I'd just like to highlight that just in a similar way that GeneXpert became widely available in the African continent and very many other LMICs through the advocacy of organizations like Find Diagnostics, I am happy to report that Find is also trying very hard to make CGMs more accessible to developing countries, especially for the benefit of type 1 diabetics, who more often than not are little children. And so we really applaud such interventions to try and make this, from a health equity standpoint, try and make CGMs accessible to LMICs. So in summary, what have I said? One, that indeed CGM has revolutionized diabetes management globally. We hope to enjoy the same benefits in LMICs, and the benefits are directly linked to how long you actually use the devices and how you actually respond to the data that you're given. The data on its own doesn't make a difference. Secondly, that laboratory professionals are integral to adoption of CGM. As we have seen, IFCC has played a very important role in defining analytical performance and acceptance criteria, and we also need to be up to date with how to actually interpret an ambulatory glucose profile. Lastly, it is important to know the limitations of CGM, and that CGM cannot entirely replace blood glucose measurement. We actually encourage people, before you actually change your insulin dose, do a finger prick, do a blood glucose measurement. So there is still a role of our traditional lab testing or actual testing of biological samples in vitro. We still have a job. No one is taking us or pushing us away. So thank you very much for your attention.
Thank you. Thank you very much, Jeffrey. We have about 12 minutes for questions. If you have any questions, you're welcome to type them in and we can go through them. We've already had quite a few questions come in already. We probably have a few thousand people online at the moment attending the session. So we will. I'll start off with the first question from one of the attendees that came in very early, and I see we're missing Adil Khan.
I should be here. Can you see me?
You're still there.
Yeah.
We can't see you, but it's fine. We can hear you. So Ravinder Singh from the Mayo Clinic is asking how many new point of care tests have been brought into the clinic in the last 2 years. I don't know if anyone wants to tackle that, which is quite a tricky question because my sense is that there are not many new tests. It's usually new devices that use new devices for established tests and new ways of doing established tests. But I'm not sure if there's a numeric answer to that, Ravinder. And I know the market is growing about 12 to 15% a year, but that's probably mostly just same old tests, but new devices. I don't know if anyone else has any insights into that. Adil, from where you are in the US?
I would agree with you. I mean, some of the tests that, that like continuous glucose monitoring is an ideal one, where it's a glucose test, but it's been, there's a different way it's been now delivered. So, there are, in the US, you've got the FDA, so that makes it more harder to know which one is really, in the rest of the world, sometimes the tests come out much more faster. I know people are looking at cancer biomarkers, but there's nothing that's been approved in the FDA yet.
Okay. Another question
Can you
from...
see me now?
Pardon? Yes, we can hear you. We can't see you, though.
Yeah, for some reason, you should be seeing me.
Check
Because
your
I'm not
camera.
sure what's the...
Icon of the camera. Can you see that?
Yeah, I can.
Okay, let's go to the next question from Ravinder again. What are the major advances in technology which assures that results are much more quantitative and comparable to the main platforms? Does anyone want to tackle that? I suppose the answer to that, I would say miniaturization and portability, integration of advanced detection methods, automation and robotics, certainly. I would say wireless connectivity, data management, and then multiplex testing, multiplex and panel testing, probably are some of the advances that have made the POCT instruments more comparable to big platforms. Yes, Lena?
Yeah, so also there are, there's a noise that, there are vendors who are working in tackling the issues with non-integrated POCT and bringing out devices in which you can scan the lateral chromatography and take picture and, transmit it to the software. So there is little advancement in that area also.
Okay.
But not in LMIC, it is, still under research and, under observation, yeah.
We can go into the next question from Nazri Juanda. For point of care test devices that are not interfaced to any middleware system, what are the minimal requirements for the manual reporting template?
Can I take this one?
Yeah, go ahead.
Okay, so like I said that you need to assess the need and the utility of the test, the non-integrated test that you want to initiate or have in mind, because it's very important to keep the QC or the QC plan stringent depending on the utility and how it is utilized. If big decisions are taking on it and it's a diagnostic test, then you would like to keep uh, the QC checks as like any integrated POCT, for example, like glucometer being used within the ER or critical care areas. And then even if it's manual, review of manual records and everything is manual, you would still like to keep it very stringent and very, keep a close eye and oversight of the lab. So it depends on the test that you have in mind and how it is used. So patient safety, whenever patient safety or patient outcome is at stake, you need to be very strict. So you follow the same guidelines like you do in the lab.
Thank you. I see, Nazri, you've asked a few more questions, but I'm just going to go on to a few others to give everyone a chance to answer and also to give other attendees a chance. There's one from Sandra Chiwanza asking, and this is probably for Jeffrey, there's a lot of data to process from CGM, and can we not set it up to collect data? Jeffrey?
I'm not too sure I understand when she says, can we set it up just to collect data? So I think I'll answer that question in two ways. So yes, there's a lot of data. It can be extremely overwhelming, and that's our experience. But there is a role for use of the professional CGMs, where a healthcare provider can actually blind you as a patient to the data. And you have a sensor installed. We monitor your data for 14 days. And you come back to me as a doctor. I download the data, and we have a discussion around what is working for you, what is not working, and how do your glucose levels change based on your diet, based on exercise, based on insulin. Now, there is also the option of using the intermittently scanned CGM. So if all the data is from a real-time CGM would overwhelm you, then maybe an intermittently scanned CGM might work best for you, because in an intermittently scanned, you consciously go and scan the sensor and download all the data. So you're not really being bombarded all the time with all of this really mass information. And it's important to sort of realize that the whole role of a CGM is to help optimize your treatment. And once you're able to achieve certain set target goals, you don't need to keep on using it all the time. So you don't have to be on lifelong CGM monitoring if your glucose is your glucose levels are fairly well controlled. So you might be overwhelmed for the period that we are trying to optimize your treatment, but you don't have to be on it lifelong. There's really no point of having a CGM if your glucose is well controlled. So you can just bear with the data, with all this data for a short period of time as we're trying to optimize your treatment. So I think that would be my response to her.
Thank you. We'll go on to the next question from William Lung Chi-Ching from Queen Mary Hospital, who asks, how is cloud-based technology integrated in POCT management? And is it a complete solution to fulfilling the new ISO 15189 2022 requirements? There have been a couple of questions about ISO 15189 as to whether it has integrated POCT into the standard. Anyone want to tackle that?
I think I'll have a start.
Ahead.
I mean, I think one of the requirements in any regulation is to make sure that the results get into the patient's chart. So that's usually the theme. How that is achieved can vary.
Yeah,
go ahead.
So yes, and traceability of results is very important as per the guidelines with the regulatory body ISO 15189. That it's very important that who has done the test and has reported the test. So the traceability where it was done in my home, so that is also very important.
And then,
maybe I'll just add to what Lina said. I think so. In our hospital, one of the challenges we had with the non-integrated POCT was trying to demonstrate objectively to an auditor that if there was an alert value on, say, an analog digital glucometer, what evidence do you have that the clinician was actually informed and that the clinician actually responded to that alert value? And so I think it is important, even as we talk about integrating our glucometers, how do we ensure that the loop in terms of a result is generated, it's communicated, and that is an action, especially for clinical, for critical values, that loop is actually maintained. So I think it's very important, even as we talk about integration, that we actually ensure that people are actually acting on alert values. So that should actually be one of the benefits for integrating.
Thank you. There's a question here from Kulud Hikmi from Tunisia. Can POCT be managed by a clinician after a quick training session, or does it require the presence of a biologist in situ to ensure reliable results? And if the device uses a validated method, do the results need to be rechecked in the laboratory, or are they sufficient? Interesting question, very relevant. Who would like to tackle that?
I can take it.
Good.
Okay, so there are parts that, this isn't a single question. There are, lots of many questions in this question. So one part I would like to tackle that, yes, worldwide and globally, and also with evidence, I'm saying that point of care testing programs should be led by clinical chemists or chemical pathologists or pathologists from any clinical laboratory. Why? Because the importance and the knowledge of the correct test and the reliability of the test lies with us and not with the clinicians. Many of times, if you interact with them, there are few queries, that they are not able to handle and put forward to you. So it's very important for us to take responsibility and oversight of all the phases of testing, from the time of initiation, validation, till competency assessment, as per regulatory standards. Also, why? Because the physicians do not have enough knowledge of the whole process. You might teach them a little part of POCT program, but the whole process and regulatory standards are all well known to the lab professionals.
Thank you very much. Unfortunately, there are quite a few unanswered questions. For those who still have questions, we've run out of time because we've just hit the 90-minute, just over the 90-minute mark. So we're going to have to end the session. But for those of you who still have questions, those can be replied to via email for those who pose the questions. But I'd like to thank you, the audience, for attending this webinar, and I'd like to thank Professor Khan, Adil Khan, Professor Lina Jaffrey, and Professor Jeffrey Omuse for the interesting presentations and the valuable information that they've provided on the topic that we discussed. I would also like to thank Dr. Paul Hamilton for coordinating this webinar and all the other webinar series, and to the International Federation of Clinical Chemistry and Laboratory Medicine, the IFCC, for offering this opportunity for e-learning. So there will be a certificate of participation that's going to be provided at the end of this webinar after you answer a few questions. And then you can also, at the end of the questions, click to show your scores at the end of the page and get your certificate. And then you can also, for the sections that you may have missed, you can go back and review this webinar on demand, as the recording will have been saved, and you'll be informed about that by email. And then there will also be in this series, other IFCC webinars that will come up and will be announced through the usual IFCC channels, email, website, and the IFCC social media. So once again, I want to thank the audience for attending and for your participation. Thank you, and good night, good morning, and goodbye. Thank you.
Thanks.